to thank Stony Brook Eastern Long Island Hospital for setting this up, and Dr. Stanton for being here. And to do a little brief introduction, we have Sonia, who is the Director of Marketing and Development, and she will introduce Dr. Stanton for us. Thank you so much.
Okay, I got my glasses on, I can't see. All right, for those of you that don't know Dr. Stanton yet, I know there's a couple of people here that already do. Dr. Stanton is a clinical assistant professor specializing in non-surgical interventional spine and sports medicine care in Greenport, Hampton Bays, and the surrounding areas. He will explain exactly what that means in proper language. He was born and raised on Long Island, and he's very excited to be here serving East End communities. His approach to spine and musculoskeletal care is to be aggressive with diagnosis and conservative with treatment. A quote from Dr. Stanton is, "I have specific interests in treating sports-related injuries and returning patients to their highest level of performance at work, sports and recreational exercise. The concept of precision medicine is one that I apply to each of my patients. The right treatment for the right patient at the right time." Dr. Stanton is an interventional physiatrist who completed his fellowship training in spine and sports medicine at the Hospital for Special Surgery in New York, New York. He completed his physiatry residency at Kingsbrook Rehabilitation Institute in Brooklyn, New York, where he served as chief resident. Dr. Stanton completed a surgical internship at North Shore University Hospital in Manhasset, and he also completed his medical degree at St. George's University of Medicine in Grenada, West Indies. Welcome, Dr. Stanton. Thank you for being here.
All right, everybody. So I know a couple of folks out in the crowd here today. It's nice because it's a small group, so any questions that you may have about anything that's discussed, I'd be happy to go into some greater detail or whatever it is to help kind of elaborate or understand better. So everyone leaves here kind of with a better idea about spinal stenosis, which is the primary topic today. And rather than providing like a laundry list of all the treatments that exist for it, I'm really showcasing one more innovative treatment that I find exciting, the mild procedure. So without further ado here, I'm going to kind of angle myself so that I can get a good look at the slides as well. So just to give you a little background about myself, so I'm a physiatrist, so that's a non-surgical, muscle, bone, nerve doctor, basically. And so my specific interest is spine and then sports medicine and non-surgical methods of treating that through procedures. So that would be, injection-based procedures and other sort of minimally invasive, even surgical type procedures. That is coupled with physical therapy generally. It's a big tenet of my sort of mantra to managing these sorts of conditions, to sort of work on the issue itself through with the procedure, sort of the physiology and the pathology, the problem itself, but then also address the mechanics, sort of how you function, making sure that your function is optimized and support for the area that we're treating is optimized as well. So so this is kind of that, I call it kind of the 1-2 punch, sort of to try and get after a certain condition. You don't want to just do a procedure, but you want to support that with some sort of rehabilitative effort as well to maximize your outcome. So the mild procedure, mild stands for minimally invasive lumbar decompression procedure, is to essentially work on spinal stenosis, lumbar stenosis, which is a condition that really interferes with how patients stand and walk primarily. It's typically very disruptive of overall daily function. So particularly if you wanted to elaborate on spinal stenosis, there's a condition that goes with it oftentimes in the lumbar spine known as neurogenic claudication. And we'll talk a little bit about that as I go through some of the anatomy slides. But this is more or less the leg pain, the component of leg pain that goes along with spinal stenosis, where folks often would describe some sort of radiating pain or numbness or fatigue, heaviness in the legs that accompanies, the spine symptoms, or occurs in isolation without spine symptoms. Lumbar stenosis doesn't always have, back pain or what we call axial symptoms. That is the primary feature. Sometimes the symptoms alone are just leg symptoms. So, what we have here is, kind of a very healthy, cross-section of the lumbar spine, and then, one that is typical of an aging spine. So on the cross-section, the spine in the lumbar region, this is kind of you're laying on your back, your belly's up this way, skin over your back would be this way. The disc space is here in the front, which is the cushion of the spine. The spinal canal is where the nerves are, and then off to the sides you have the joints, and then obviously the nerves that are exiting the spinal canal. And so what you're seeing here on this side is degeneration of the disc space in terms of a protrusion of the disc, aging joints, which are looking roughened in their appearance and enlarged even as they age. And then there's also this V-shaped ligament back here that as we age becomes more sort of redundant, like it's kind of squished and as a result becomes enlarged and hypertrophy, as we say. And so this combination of crowding from the front, from wear and tear of the disc space, crowding from the back, from the posterior elements in this ligament area, and this eventual decrease in space in the middle, and narrowing with bony overgrowth. And so basically that results in irritation of the spinal nerves, and then these downstream symptoms involving the legs. Because in the lumbar spine, the nerve roots that run through it are the ones that supply your buttocks, hips, thighs, all the way down to your toes, depending on which nerve root we're talking about, all right? So oftentimes this is, kind of the end up is that folks are really dependent upon kind of that forward-leaning posture to create some space in this canal where they've lost that, critical room for the nerves to function well. And so oftentimes, these folks will end up, describing that they like to walk with a shopping cart, that they like to, use a rolling walker when available, sit and bend forward at the waist, to kind of alleviate the symptoms. These are very, very common complaints and sort of features of this syndrome. So there's a large number of folks that are actively being treated in the United States, 2 million at least, and 20% of folks, right? So 1 in 5 over the age of 60 have, spinal stenosis of some degree. So again, this is this kind of forward-leaning posture that we see in this subset of patients that have spinal stenosis, and then obviously it's usually seen most in folks over the age of 60, but not to exclusion. There's certainly younger folks that develop this as well. Typically, like we talked about, pain, numbness, heaviness, tingling in the back, but mainly in the legs when you're standing or walking. You spend more time sitting as a result because that seated position affords that forward sort of flexion of the spine and creates a little bit of critical space there to alleviate nerve stress. Patients will sometimes like to be sleeping in the fetal position, kind of flexed again, or forward flexed with the shopping cart as we talked about, or a cane, or some other walking aid. And then, oftentimes, patients have been through a lot of different types of treatments, whether it's over-the-counter medications, heavier pain medications, opiates in some cases. They've worked through with a physical therapist with, kind of, plateauing on the benefit there. Had some epidural steroid injections perhaps to help with this, and which can be extremely beneficial in the right setting, but oftentimes, ultimately, you reach a bit of an impasse where it's not effective, and now what? So, so this is kind of another schematic here of the same picture. So it shows this hypertrophic ligamentum flavum, which I talked about, that V ligament contributing up to 85% of spinal canal narrowing. It shows this compression of the sac that holds the nerves, which is known as the thecal sac. And then basically nerve root inflammation is the resulting issue, and that's what contributes to the symptoms involving the legs. Now the mild procedure really targets this ligament, okay, as a, as sort of a target for treatment. And we'll talk about that a little bit. But, kind of the surgical approach to managing this, just to, sort of go down that road, is usually focused around removing bone and, and oftentimes removing this ligament, in the posterior, so decompressing this posterior aspect of the spine by removing some bone and ligament. But obviously that requires, major operation, right? It's undergoing general anesthesia, and comes with a certain degree of risk and, also some risk of also, kind of non-response to a procedure that's, much more of a commitment in that sense. So when we look here, the idea is that you have this kind of bottleneck beforehand with, with the spinal stenosis, and that afterward, when you go through the, any sort of decompression of the spine, the idea is to remove that kink, and sort of have a better, a better avenue for the nerves to travel without being impeded and, irritated. I would say, not that this image is misleading to some degree, but I think it's slightly misleading because obviously some of this, right in the front, this is a degenerative disc that's kind of pushing back on the fecal sac, and that's not going to be removed during a mild procedure. And mild, you're really looking to remove the posterior kink, so to speak, and just create a couple of extra millimeters of space to alleviate, the nerves. Again, like when you sit and bend forward at the waist, you're only creating a very subtle amount of spatial relief there. So we know that it doesn't take much to tip these symptoms in a positive direction. It's trying to kind of find some space to alleviate that irritation, all right? And the advantage of doing the mild is that it's done, through like a very tiny incision, like a 5 millimeter, little incision. There's no, major incision to recover from, or post-operative recovery period and things of that nature. Essentially, there's no general anesthesia. It's all done under a very light IV anesthesia. If you're to have this procedure, there's no implants. There's no fusion of the spine. No medications, steroids, opiates, no sutures. So, kind of like I said, a very sort of minimal ambulatory procedure. So basically, it's a broad spectrum of folks that would be, candidates for this. Kind of all lumbar levels are in play, from L1, L2 down to L5, S1. Folks that may be a good candidate for this are ones that, for whatever reason, are trying to avoid surgery. Maybe they're not a good surgical candidate because they have other medical conditions that limit them from an anesthesia standpoint, right? I mean, anesthesia has to clear you medically to have an operation. It might be, also that you have poor bone density, and a surgeon says, you know what, I don't want to do a fusion procedure on your bones because I don't think you'll heal well. And so this may be a good option in cases like that. And obviously there's the, sort of case where a patient says, like, I just like to avoid surgery, if I can, a big surgery, and see if there's an in-between step here to treat this effectively. So, that's just, makes sense as well. Kind of avail yourself of what's available to you before you, kind of jump to the most, drastic option. It just describes that, in the presentation, that if you've had prior surgery, or you have a malalignment, a spondylolisthesis, or it says your bone integrity is compromised, osteoporosis, these sorts of things, that this procedure is an option for you. It just describes that, that there's increased patient access for the procedure, that, Medicare is covering this, which is, obviously a very important piece of the puzzle, right, that you can actually get it done. Because, there's a lot of great technology that exists in, in medicine, but not all of it is accessible because of cost and lack of coverage widely. The durability of the procedure, right? So that's an important piece of the puzzle. So when we do something, we want to, so folks always will ask me, generally as a matter of course, how long is this going to last? And so, there have been studies that have been done that follow patients longitudinally over a number of years and find that, 5-year durability is, like near 90% in terms of, the outcome that you achieve. So 88% of folks avoided back surgery for at least 5 years. And, that's it's a pretty nice, alternative to undergoing the surgery, because you have to realize that with surgery of the spine is that, those surgeries aren't forever. You have an operation oftentimes to treat the spine, and a number of years down the line, there is an adjacent segment that becomes a problem, meaning a segment next to the operative segment that you had sort of fixed. That then becomes an issue, and now it's like, now what do you do? Do you do another operation, or how do you manage that? And so anything you can do to kind of hold off a surgery is generally a good idea when it comes to the spine, specifically because of that aspect where it tends to be somewhat time sensitive there, where as time goes on, it doesn't always bode well for the outcome, right? And then the chances of recurrence or adjacent segment disease kind of go up. There's excellent functional improvement that's seen, and there's some other slides that kind of speak to that. There have been a number of studies that have been published to look at this procedure particularly. And it has an excellent safety profile. So that's the biggest thing from my standpoint, is that it's a very safe procedure. It has safety that's equivalent to an epidural steroid injection, which is extremely safe. Like, I've done tens of thousands of epidural steroid injections for patients in my career so far, and I've never had a problem or a complication to speak of, anything significant. And I'll say, this is the same sort of safety profile, which really makes me comfortable with it. So long-term outcomes. So they're basically talking about, what are we seeing here in terms of like that scale of 1 to 10 that doctors will often ask you about, scale of 1 to 10, what's your pain, 10 being the worst you can imagine, and 0 being no pain. Folks starting off, somewhere in the, 8.5 to 9 range, let's say, seeing this drop off of, kind of a mean drop off of about 5 points down to like towards like a 3. I think that that's realistic to realize that it's not a panacea. These sort of things aren't going to make all pain go away, but it's trying to bring you back to a more functional place where, can you deal with 8 out of 10 pain all the time? Probably not. You're probably not going to function very well with that level of pain. But can you deal with a 3? Probably. And you'll probably be able to function fairly well through that sort of discomfort. You have to realize that because it's a multifaceted disease process, there's more than one pain source. It's not just the spinal stenosis that causes your back pain. There's degenerative arthritis mixed in. There's degenerative disc disease. There's all these other things that are sort of causing the bulk of the symptoms. So when you address one, it doesn't mean you've addressed all, sources of pain. But what we really are trying to target in this specific case is what limits you from being able to stand and walk for any length of time, kind of giving you that improved ability to tolerate weight-bearing activity. So the long-term outcomes here, right? So basically, again, we're talking about 2-year follow-up, effective for patients with comorbidities. So, so again, there's a number of different types of spinal stenosis. There's this recess narrowing, right? There's the more central stenosis, the contributing factors, the discs that are wearing down, the joints that are enlarged, and this hypertrophic ligamentum flavum. So one thing that this presentation doesn't really have is kind of a schematic or an outline of how the procedure is performed. And so the target being that this ligament, basically the way you target this, there's 2 instruments used during the procedure. One is a small bone instrument that takes a little bit of these bony osteophytes off the back edge of the posterior elements here to create an access area. So you kind of go in and chip off a couple of small osteophytes, because generally there are these osteophytes in these cases. And once you created a little access portal, then you can take the ligament sculpting tool and put that in, and that's contoured for safety with a rounded edge to it, so that it doesn't pierce through the ligament, but that it kind of scoops out some of the ligament. So the idea there is it has a sharp edge to it, but it's rounded this way, so it kind of scoops into the ligament, and then you remove small amounts of the ligament. So you take, like, let's say a few samples from the one side that you remove, and then again from the opposite side you take some tissue there. And in the end, what you're doing is debulking the ligament. Okay, so that's the idea behind it. You're not removing the whole thing. You're not, doing some massive decompression where you're taking out a whole lot of bone. You're just creating a small access point, and then taking out, as much of the ligament as is sort of reasonable to get to with these instruments. And in the end, the outcomes are very impressive. So, the functional improvement, again, the standing time was seen to go up like 600%, so folks are able to stand, 7 times longer than where they started. Again, people in these cases, their average standing time was like around 8 minutes. And I think a lot of folks might even overestimate how long they stand for in my experience. So they're like, well, I think I can probably stand 30 minutes or so. That's a lot of standing, really. What was really found when it was studied is that most folks were really not able to tolerate more than 8 minutes, and afterwards they're up to almost an hour. Which is a lot. That's a long time to be up on your feet, standing, or obviously walking for that matter. Walking distance, they saw 1,500% improvement, right? So 246 feet was kind of the baseline, and then we're seeing short of a mile, but about 4,000 feet, right? And miles just over 5,000. So certainly pretty impressive there. When you compare the functional, what you're able to do in that distance versus that distance in a day. And the safety profile, again, these sort of adverse events, being in this kind of like 1% range. Again, it doesn't leave, to say it removes the problem. I would say it debulks the problem. It removes some of the issue, but it doesn't leave anything behind, right? We're not putting anything in, any foreign body, anything metallic. There's no, nothing along those lines, to be, concerned about. We're not concerned afterwards of spinal fractures or things of that nature, because, when you do let's say a fusion where you put in screws and implants and all this, sometimes it overstresses certain areas of the spine and can create, some downstream fractures. And the other piece of it is like when a lot of bone is removed from the spine, there can be instability that is created as a downstream issue, and in this case, there is not. These are very, very minute, sort of bone osteophytes, like bone spurs that are removed, actually, when you're doing this procedure. So it compares. There's a bit of a comparison slide to some other devices, Superion and X-Stop, versus just your standard surgical decompression. And he talks about kind of device-related adverse effects and any rate and fusions, obviously. So there's fusions carry much more of these device and procedure-related adverse events, and then the idea of like kind of reoperation, again, high rates of reoperation, of needing something else, where mild is much lower, in all those categories. So very appealing from the safety profile and that sort of downstream outlook, so to speak. So, and then the patient satisfaction is high. 85% patient satisfaction. These are 24-hour recovery afterwards. Really, it's not. There's not. aside from, kind of waking up from, an IV sedation, it's the same type of sedation you'd have for like a colonoscopy. It doesn't, leave you really with much of a post-op recovery period. You take it easy that day, and the next day you can kind of get back to whatever you can tolerate. There's no real, limitations in terms of like what you're able to do. But, we do see that the improvements after the mild are sort of seen over the course of like 4 to 6 weeks. They're not immediate, because again, your spine has to kind of, the spinal nerves have to kind of now acclimate to a change in their environment. And then there's, some, sort of post recovery from that standpoint until you see the results, kind of bear out. So that's the end of this, sort of presentation on the mild and all of that. And I'd be, happy to, answer any questions here. I don't want to, burden this with too much talking. I mean, you can go on and on forever in terms of, presenting, these sorts of cases and so forth. But, a lot of times it's great to hear what you all have in terms of personal questions to answer. Yeah.
I wonder if you could explain, so that I could understand it, the difference between herniated discs, which I have, and stenosis.
Okay.
And would this be appropriate for herniated discs?
Yeah. So the wear and tear process of a disc. Okay. So let's go back to the slide that has, there it is, the healthy disc versus, the worn disc. So if you can kind of make out from where you're sitting, there's this sort of central area of the disc that's like a slightly different color here. Everyone see that? And then there's this portion on the outside that's like kind of thickened belt of tissue that surrounds the disc. And so the substance in the center of the disc is known as the nucleus pulposus. It's the jelly-like substance in the center portion of the disc that gives the disc its quality of being squishy, basically, a shock absorber. And then the nucleus pulposus is then surrounded by the annulus fibrosus, these fibers that are like concentric rings, like annular rings on a tree of like a tougher sort of fibrous type of material that bind that nucleus together and keep it, a nicely, from like an engineering standpoint, contained shock absorbing unit. Now, throughout your life, when you acquire wear and tear, it happens in the way of, little tears in these annular fibers. That's just kind of how they, sort of wear down over time. Now, when you tear through a number of those fibers, the shape of the disc changes. It doesn't retain this nice shape here, to provide relief for the spinal canal. It might bulge and sort of, kind of move in this direction. That's actually called a bulging disc. Folks say, I have a disc bulge. That's what a disc bulge is. It's kind of like that first stage of wear and tear of a disc, where it's kind of just, evenly sort of extending along the back edge of it and so forth. And in that state, it can or doesn't, it oftentimes doesn't hurt. A lot of times, most disc bulges don't cause any problems. They happen. It's just a matter of wear and tear of the structure. But when you acquire wear and tear of the structure, it opens the door for greater vulnerability to inflammation and irritation, and for the structure to start to hurt. As you tear through those annular fibers in more of like an asymmetric pattern, or it happens more, let's say, in this case, this is like the right side of the disc because the person's laying down, feet facing us, generally speaking, in terms of like an MRI. You're tearing through this portion of the disc, and then you end up with a protrusion where some of that nucleus material is pushing through those tears, and that creates more of a protrusion, which is like, sometimes it can be central, like right in the midline. Oftentimes it's off to one side slightly or another, and then it leads to nerve irritation as well that can run down one or both legs. Sometimes it just causes back pain, so it's kind of a variety of symptoms that come from the disc as it wears down. But whether it's a bulge of the disc, a herniation, whatever protrusion, whatever it is, that's kind of, it's a different stage of the wear and tear process and a different morphology or kind of look to the disc as it's wearing down because of how it is sort of tearing on maybe midline or off to one side or the other. So this is more of a herniation, and then bulge would be more just extending evenly across the back edge. Yeah.
So the follow-up question is, would this procedure, the mild procedure, be appropriate for bulging discs?
Yeah.
And if so, what advantage is there over the epidurals?
So if you have associated spinal stenosis, like this is a protrusion, but the person also has spinal stenosis because they have these other factors that lead to the crowding effect. Not all disc protrusions have spinal stenosis associated with them, right? You can have a wide open spinal canal with the disc herniation. So you've got to make that assessment of whether or not there's stenosis present, and then whether or not you feel like the stenosis is really the primary contributor to the person's pain. And even if they have spinal stenosis, epidural steroid injections could still be effective, very effective sometimes, or you don't need to do the mild, So it's kind of like the mild is there as an option, it's like if you're failing treatment options, like you're failing rehabilitation, failing epidural steroid injections, those sorts of things are not holding for you, So it's not something you just jump right to.
Okay.
Yeah.
Can I ask so you have a healthy ligament, and then as you age, is it the ligament that's actually changing? Is there something going on, which is why is it thickening up?
What's happening is, like I said, it kind of becomes redundant on itself. Like the disc is wearing down, and as the disc wears down from like the y-axis, like you're losing height in that disc. So this same tissue here is not as expanded as it once was. Now it's becoming like foreshortened and redundant upon itself. So it starts to thicken, and as sort of part of the wear and tear process, it also starts to become thickened, kind of like worn down joints become hypertrophic, like beefier as they start to wear down. So it's partly because of a shortening of the spine that happens, like we lose our height in our spines, right? So as the ligament starts to foreshorten and become redundant upon itself, it thickens, and then it also it's a response to wear and tear as well.
So doing this procedure, you're reducing the ligament. You're making the ligament smaller.
Debulking it. Yeah.
Okay. But does that also have some? I mean, the ligament's there for a reason, obviously, to hold everything.
Yeah, no, that's.
If you lost ligament completely, what would happen?
Right. Well, when someone has a spinal decompressive surgery, they do. Like the surgeon goes in and removes that ligament completely.
And then they fuse the spine.
Not necessarily. No, sometimes they just do like a laminectomy, like some folks may have heard that, or a hemilaminectomy, where a surgeon would come in and hemilaminectomy would just removing like half. It's like, let's say your symptoms only involve this side. They might just decompress this side and take out this portion of the ligament, or they take out the entire ligament, but they just remove this piece of the bone and leave this behind. But the ligament's generally completely removed during decompressions. This leaves ligament, it just debulks it. So yeah, the ligament is not removed altogether at all. So it has that sort of preservation aspect to it as well. So you're trying to kind of preserve the anatomy, but at the same time kind of just work around the stenosis and just create some critical millimeters of space that you've lost. Yeah.
I have two questions. One, how effective do you think appropriate physical therapy is for increasing the space here and putting off surgery?
So, and then two?
Two is, I have stenosis, but I also have peripheral neuropathy.
Okay.
And I've had a couple of doctors say the peripheral neuropathy, they can draw a straight line to the spinal stenosis as the cause.
Okay. So, all right. So I think, right. So the physical therapy doesn't create space.
Doesn't?
Does not. No, it doesn't create space. What physical therapy does is it creates support. And it creates better mechanics that affect the spine. So that's like a whole big lecture series probably in and of itself. So, to try and simplify that, to, a couple of sentences, basically, as you age, certain muscles, critical muscles and core muscles that surround the spine very, very intimately surround the spine, weaken. That happens. So they start to weaken, they start to atrophy. So your spine is segmentally less well supported. So basically, movements that are not intended occur, and are maybe exaggerated movements that were once in your life supported much better and were not present. Postures change throughout your life, right? So folks might develop a more exaggerated curvature to the spine, like a lordotic curvature or a flattening of the spine, and so those can be extremely that can be problematic. And then muscle groups tighten over your lifetime, right? Like for instance, let's just take a very common one, the hamstrings. It's extremely common for me to examine a patient with spinal stenosis and find that they have extremely tight hamstrings. So tight hamstrings, this is just one example, but tight hamstrings would generally pull a patient into extension because of the foreshortening of the posterior cord from the knee to the hip. And in doing so, putting the spine in a position of extension that has stenosis is a big problem, right? That's what you generally are fighting to do in stenosis is get forward, and instead your lumbopelvic junction is being rotated in a way that extends the spine. So what you're doing with PT is you're trying to improve the mechanics to have less of those sort of deleterious changes that are happening, anatomically, sort of happening that pull you in the wrong direction functionally, right? And start to make your symptoms worse. So make you more flexible, but yet more stable. That's the kind of the balance of PT that you're trying to achieve. So
So it just slows it down, in a nutshell.
well, I mean, it's not even, it doesn't even affect the actual wear and tear process. It just affects the mechanics, of what is, the movements of your body, sort of how your muscle groups are firing, how strong those muscle groups are, atrophied muscle groups making a comeback in terms of strength, and then building flexibility in areas that you've lost it. So all those things, and it's also retraining, postural training, all sorts of things that, and not to mention just your mechanics in general. Working with a physical therapist can be tremendously insightful just in terms of how you bend and lift. They kind of go over these, very simple things that you take for granted maybe and understand that you know how to do them well, but you really started doing them poorly. And so, they kind of dissect some of those things and help you with it, and it can make a tremendous change without changing anything physically, right? It just, in terms of the pathology of itself, doesn't change the pathology, but your body is functioning better despite it, So that's the idea.
Thank you.
Yeah.
What about the peripheral neuropathy?
Oh, peripheral neuropathy side of things. I mean,
Does that come from stenosis?
I mean, that anecdotal sort of I draw a straight line to, I think, look, we see more peripheral neuropathy in folks over the age of 60. We also see high rates of spinal stenosis in over 60. So I just think you're examining something in the same sample of patients. So you're seeing something that the frequency of it is increased on both, both categories, right? So I just think it's not necessarily the one is related to the other, and they have overlapping symptomatology, So peripheral neuropathy, basically you're seeing numbness and tingling in the extremities, loss of balance, things like that. Same things you see in spinal stenosis. You'll see along with pain, or sometimes it's not painful, it's just intense tingling that you get throughout the extremity into the distal aspect, the feet and whatever, in this case. So yeah, I think a lot of them have overlapping symptoms, and then you're really dealing with the same age group as a predominant issue as well, that they have in common. So I'm not sure that they're actually related, but yeah, a lot of the same stuff they'll wrestle with. Yeah.
When you have a pain down your leg and gets close to your knee, should you have to do some work on your knee too? Because that doesn't go all the way down the leg, it stops at my knee.
Yeah, I mean, you know, the spinal nerves, so some of the nerves, you know, terminate above the knee, you know, like for instance, you know, like if you're like the L1, L2, L3 nerves, you're talking about like mainly are the knee up, you know, L4, L5, S1, those are the ones that really are going to run distal to the knee, you know, in terms of the mapping of the nerve, neuroanatomy of it, and where they go. So sometimes the nerve, it's running the whole distance of the nerve tract, but you know, that dermatome that it runs in, or you know, sort of the myotomal pattern that it affects, you know, only involves like, you know, down through the thigh, you know, so so you're saying like, do you work the knee as well into your PT? Is that what you mean?
Yeah.
I mean, as a matter of course, I mean, if you know you have a bad joint there, you know, that can definitely be the fly in the ointment for that side of your lower extremities, and that can certainly contribute to more active stenosis symptoms. That's the other thing, you know, when you have spinal stenosis, if you have a failing, I'd say large joint, you know, hip, knee, that's really failing you, it's far more common, in my experience, to see active spinal stenosis. So, like I see patients all the time that I would say have inactive spinal stenosis. They have stenosis that we find, but it's not causing typical stenosis symptoms. And maybe they have some back pain, but it's very severe stenosis, but it's not causing any nerve pain. But if they develop, let's say, you know, a really severe irritation of you know, a nerve that through the stenosis, oftentimes can be because you know their gait is compromised or how their function is compromised because they can't walk well on a hip that's giving them, you know, trouble, so they're, you know, sort of off to the side, you know, limping, antalgic in their gait pattern, and it sets off the stenosis. It makes it more active because it's an asymmetric, you know, functional pattern of movement. So biomechanics are huge when it comes to this, and that's kind of what I allude to with the physical therapy, and that's, you know, kind of the complexity of this, as it also pertains to like you know, wearing joints, whether it's a, you know, a knee, a hip, an ankle for that matter. Yeah.
What about supplements and diet? Can that sort of manage or slow down this whole process?
I mean, diet as it pertains to maintaining an optimal weight, definitely. But like specific things to eat for stenosis, not as much. You know, like being a good weight is key for any sort of arthritic condition and certainly for spinal stenosis. And that's just using your standard sort of, you know, BMI chart, right? Like, you know, BMI is just a calculation of weight with height and so forth, and trying to find yourself in a category that's, you know, reasonable for your age group and all that. Those charts are widely available in your primary care's office. They can tell you kind of like your optimal weight that you should be targeting and all that. But that's a very big piece of the puzzle. So, you know, that's what kind of the downward spiral of stenosis stuff, because a lot of times the folks, when they're, you know, have that spinal stenosis, they don't exercise because they can't exercise because it hurts too much to exercise, so they don't, so they put weight on, and it's like, oh my gosh, how do I get out of this,
Trap.
Yeah, like they're just like, feel like they're in this vortex and aren't going anywhere. So that's when you have to really kind of find your way through alternative exercise options, whether it's swimming, whether it's like a stationary bicycle, you know, these types of alternative ways of burning calories, you know, exercising basically aerobically to stay fit, you know, and you know, being flexible to say like, well, exercise can't just look like one thing, you know, it can't be like either I can go out and I can walk or I just can't exercise. If you're that, you know, sort of limited in your own mind, you're not going to be able to work around this type of condition, you know, so.
And then what about supplements like vitamin B?
Vitamin, did you say D?
B.
Not as it pertains to spinal stenosis, you know.
For nerves, I thought that was.
Yeah, I mean, it's, you know, I get it. Like there are nutrients for nerves that are helpful, but that's more, you know, you're talking like kind of more peripheral nerves and things like that, you know, that are like the small nerve fiber disease stuff that this isn't really, you know, as germane, I don't think, for that. You know, this is really something that you want to manage mostly with the right exercise program, and then coupling that with the right procedures to help keep it at bay. That's kind of the I think that's like the best approach. But you want to combine it to address both the problem and the biomechanics.
So sleeping in a fetal position, is that,
It creates flexion, so it creates a little space.
and that's not like going to do anything to improve it, it's just going to make you more comfortable.
Yes. Yeah.
Yeah, that's also weird. I find standing much easier than sitting.
I mean, again, like that's where your body is not reading the textbook. You know what I mean? Like, you don't have not everyone has like what they should have. And that's where I find a lot of folks are like, wow, I do so much better when I'm like walking a little bit on the move. I don't have as much pain. So I can walk pretty well. I just can't stand still. Right? Yeah. And I have other patients that are like the opposite. They're like, they can stand okay, but they just can't walk it, any length. It's like it's a funny thing that way. It's not always this like cookie cutter. There's so many nuanced factors to it.
Probably because I have scoliosis, I have a slip disc, I have the stenosis. It's like
Yeah,
it's a combination of things, so whatever.
Right, there is. And one side might be worse than the other. You might have like, I'm worse on the right than I am on the left because of that. And when you start to look at it in greater depth and you're looking at imaging, it starts to, from a physics standpoint, make more sense because there's a different type of stenosis that's, kind of affecting one side more than the other. So this is it is not a simple, subject matter to master. You have to really,
How would you grade the best exercise for maintaining these problems? Is it swimming or walking or?
My sort of, I say, exercise of choice for folks that have known spinal stenosis is a recumbent stationary bicycle. Seated bike. The one though where you're seated like you're in a chair. Not the bike where you're upright like the Peloton, but the one that you have like a chair and then the pedals are in front of you. That's usually like the best exercise for this. Because you can do it almost without any limitations aside from like cardiovascular what you can do. So folks can get on it, ride for half hour, no problem. And it won't negatively impact you afterwards. Swimming's also generally great, but it's just so limited in terms of access that it's like not realistic for a lot of people.
When you do the bike, should you keep raising the level?
For what you can tolerate, yeah. I mean, and that's the way you're going to get sort of more aerobically out of it, definitely, and get more of like a training effect, I think that is I think one of the best choices though for spinal stenosis. I'm going to rate one at the top. So.
My therapist also gives core strengthening exercises.
That's huge. That's a huge piece of the puzzle is the core. The core muscles are the ones I was talking about. They're intimately surrounding and filling all these little recesses of the spine. When you look on an MRI, you can see them really easily. And they're not muscles that you've heard of before. They're like these nuanced small muscle groups, but they are extremely important. And those exercises are geared to target those areas that are, we know and we see through anatomic studies that just get weaker and weaker and weaker throughout your life, and they start to go away. They aren't doing what they were intended to do. So, all right.
Are there any other questions? Okay, thank you so much for
My
this.
pleasure.
Thank you all for being here.
Yeah.
Thank you.
My pleasure. All right, folks.
Thank you.